All right, well, let's get started. Good morning. As you well know, I'm Griffin Baum, one of the chief residents, and thank you, Joe, for the opportunity to give a brief overview about spinal deformities. So we'll go through a little bit of the history of spinal deformity, talk about the natural history. Don't have quite as many cases, but want to talk a little bit about some interesting techniques that we don't really see often here, but really are the bread and butter for deformity correction, especially in the adult population, and give you kind of an overview of what I see as kind of a spinal deformity curriculum and potential talks in the future that if you guys are interested, would be happy to go through. So spinal deformity is really not a new phenomenon. The earliest written accounts are as early as 3500 BC in the Hindu sacred book, which I'm not even going to attempt to pronounce. A woman was who had a curved spine was cured with pressure and upward traction on her chin, which was felt to be a gift from the gods. Later, Hippocrates was the first to describe the anatomy of the spine, and specifically described different diseases and deformities as well as proposed treatments, and developed something called the Hippocratic Ladder, which I assume only comes after the Hippocratic Oath, for treatment of spinal deformities. And here it is. It was a rigid ladder to which someone would be affixed and eventually pulled from their feet, using gravity pulling in one direction and brute force in the other. Dr. Barrow, I think we might need to have this for a resident remediation. That might be a new strategy.
Doesn't work on much different than what you do today.
No.
You just have updated CPT codes.
Exactly. This is about 97 RVUs right here. So early physicians, despite not having a great understanding of the spine, were quite interested in it. Galen, in 129 AD, to further describe the vertebral column, and his attention was specifically to the spinal nerves. He continued to be a major advocate for the use of traction, which really at this point was the only treatment available. And these early recommendations of Hippocrates and Galen, who, again, remember, very early in history, were used as evidence for treatment of spinal disorders going into the 15th century. So for centuries, our understanding was quite poor. The first use of a brace was in the 1500s. Ambroise Paré used an iron corset to treat a coronal plane deformity in a child. This was really modernized by Louis Albert Sayer, a French orthopedist who used plaster of Paris casts during axial traction, and found that this greatly improved the efficacy of traction therapy. The key advance for our understanding in spinal deformity came in 1895 with the discovery of X-rays by Röntgen, and this won him the Nobel Prize for Physics in 1901. And on the right is the famous photograph of his wife's hand showing her ring. So what is a spinal deformity? Well, really, a spinal deformity is malalignment of the spinal column in any of the following planes, and that's a coronal plane, which is a side-to-side tilt, sagittal plane, which is front-to-back, and axial, which is rotational. So we know that malalignment is abnormal alignment. What is normal alignment? And so to determine that, we use something called the Cobb angle. And so this is an example of how to measure a Cobb angle. And a Cobb angle is the angular magnitude of a spinal deformity. And so the key is to find the end vertebrae of the curve, which are the vertebrae that are maximally tilted. And you want these to be the furthest away from the apex, which should be the neutral vertebrae in the middle of a curve. And so you drop a line off of each of the end plates, and then drop a 90-degree angle from each of those. And where those two intersect is the Cobb angle. And so this measurement is key in virtually in both the coronal and sagittal planes. And so to be able to do this sufficiently is very important. And a good general note is that an instrumentation construct should not terminate at or near an apical vertebrae and should extend to the neutral vertebrae to balance forces on the deformity. And in another talk, we'll talk about proximal junctional kyphosis, and this is another key concept that, despite being so basic, seems to be overlooked time and time again. So what about measurement of sagittal malalignment? So sagittal malalignment, we use something called the central sacral vertical line, where we take a plumb line drop from the anterior portion of C7, excuse me, the middle of C7, and drop it straight down as if it had a weight on it. And what that should do is come directly over the anterior tip of the sacrum. Any deviation from that forward or backwards is measured. Forwards is plus, backwards is minus. And that's your measurement of global sagittal alignment.
That should be produced on like a 36-inch sanding film only? Like that's the only thing that's...
I mean, that's really the only accurate way to measure it, correct. In terms of axial malalignment, we use something called the Nash-Moe scale, which describes the rotation of an apical vertebrae. So imagine you're taking an AP X-ray, and here in grade 0, a normal spine, you should see one pedicle and the other pedicle, both equidistant from that central line, which should be where the spinous process is. At grade 1 is mild rotation, where the one pedicle is more prominent, the other one is still visible. Grade 2 is when there's moderate rotation, the right pedicle is still on the same right side, but the left pedicle is no longer visible. Severe rotation is when that pedicle now moves completely to the midline, and then when it's severely marked, that's grade 5 and above, you're all the way on the other side. Other key terms, and this is basic review, but lordosis, which should be seen in the cervical spine and the lumbar spine, referring to the inward curvature, and kyphosis, which is the outward curvature of the spine, which is normal in the thoracic region. Radiographic norms, and there's a wide range on these because these have been performed in multiple different ethnic groups and sexes, but normal lumbar lordosis should be somewhere between 30 and 60 degrees. Thoracic kyphosis should be approximately 10 to 40 degrees, and cervical lordosis should be 20 to 40 degrees. And as you might imagine, as one of these change, the other numbers typically change in relationship to them. But again, thinking about global balance, all these numbers should roughly equal themselves out. Jean Duboisset, really one of the fathers of our understanding of spinal deformity, introduced a concept called the cone of economy. So the idea of the cone of economy is that all of these balanced numbers will equal themselves out, enabling a person to keep their head above their pelvis and essentially be in the cone of economy, which means minimal effort to walk and stay upright, specifically painless effort. And any deviation from this cone of economy really leads to severe disability, which we tend to see more in adult spinal deformity than in juvenile or adolescent. Another key concept to understand would be spinopelvic parameters. I know I've given a previous talk about this, but I can't emphasize enough that if you're not looking at this and you're not thinking about it, especially even in just routine degenerative spinal disorders, you're missing a key piece of information that's really into a patient that may not have had one previously. So the spinopelvic parameters are a key morphometric relationship between the spine and the pelvis. And the pelvic incidence is fixed, meaning as any of these three things change, that number will still stay the same. And so it relates to sacral slope as well as pelvic tilt. And so what you do is you measure an angle of the along the end plate of the sacrum and drop a line down to measure what that tilt would be. Then you drop a line going down to the head of the femur, and then, this is the sacral slope where you have the 90-degree measuring from there. And then those two things should add up into the pelvic incidence. The key concept with the spinopelvic parameters are that to remain within the cone of economy, pelvic incidence and lumbar lordosis should be within 10 degrees of each other. And there are plenty of studies now that show that that relationship is the most important when it comes to disability in adult spinal deformity. So speaking about spinal deformities, well, so is a spinal deformity anything other than normal alignment? Is there a difference between something that's abnormal on a radiograph versus something that's truly pathological? And what about the difference between a static image, just a single, standing there, versus dynamic bending films? And so part of the problem with our understanding even to this point is that all of our measurements are done on radiographs. So this is a picture in time. There's really nothing dynamic about it. And generally they are supine images after rest, and depends on the foresight of the physician to obtain a full 36-inch standing film to really understand what the global balance parameters are. One thing that I think is important is you can't find what you don't look for. So it's very easy for your typical community, neurosurgeon, orthopedic surgeon to say, well, I don't see any patients with spinal deformities. But they probably are just getting routine lumbar x-rays and don't actually look to see what their sagittal alignment would be or if there's any coronal malalignments. And so, because we're always thinking about this in terms of global alignment, it does not depend just on the radiographs of the spine, but also includes the head, the hips, the legs, the feet. And there's quite a bit of research going into the effects of hip arthroplasty on changes in lumbar lordosis and outcomes in spinal deformity and things like that. I think that would be a good, interesting topic for a future lecture since we don't really consider any of those things. So let's run through the types of spinal deformity since this is more of an introductory talk. And so let's start with scoliosis. Scoliosis can be broken down into the known causes, which we see pretty commonly on our service, both at Eggleston and Scottish Rite. Congenital, developmental, neuromuscular, tumor-associated. And then the other side of the equation are the unknown or idiopathic causes. And those typically are not in our purview, and we don't do much thinking about it as neurosurgeons. It tends to fall to the orthopedists. But I think it's important that we've got a basic understanding of this breaks out and what the key considerations would be. And so the idiopathic forms of scoliosis can be further subdivided into infantile, which are 0 to 3 years, juvenile 4 to 10, and adolescent 10 to 18. And we'll review these, but these are not just random numbers. They're chosen because there are key changes that occur both with skeletal maturity of the spine and also the way that curves progress in those different groups. So like we just reviewed, the 3 different types of idiopathic, infantile, juvenile, and adolescent. Congenital forms, specifically osteogenic, can be hemivertebrae or a wedge-shaped vertebra, fused vertebrae, neuropathic, which we see commonly in TREAT, including tethered cord, syringomyelia, Chiari malformations, Malalignment seals, or a diastem. We've done quite a few operations at Scottish Rite on achondroplastic dwarfs who present with scoliosis. Neurofibromatosis can be a cause as well. And then you've got all of the neuromuscular and tumor-associated. Part of the reason why we do the workup that we do, which we'll review in just a second. This is a primer. I'm going to go through some of the early natural history studies, and most of these studies refer to prevalence, so not necessarily new cases, but total cases in the population. And so I think that's just an important thing to keep in mind. So the first consideration will be the differentiation between juvenile and adolescent idiopathic scoliosis. And I think the first takeaway is that any scoliosis in a child is abnormal. It's unusual and it needs to be worked up. And that's part of the reason why all of these school screening programs were implemented, because early identification is key to preventing these curves from progressing. The workup can include AP and lateral 36-inch scoliosis x-rays. Typically, especially in younger children, that includes an MRI from the craniocervical junction down to the lumbar spine. And in some of the more modern natural history studies, MRI abnormalities have been found in as many as 17% of just screened scoliosis cases. Neil?
In terms of the initial evaluation, I've run into this situation before where I've asked for like 36 films or 70 films, and I didn't know how to do that, or is there another name for those, or is it even able to be doing those settings?
No, typically not. It's just a special cassette. Radiology knows how to do it. A lot of times it's just the way that it's ordered. I mean, at Grady, it's X-ray scoliosis.
Gotcha.
Here at Emory and PowerChart, what is it? Is it 36-inch or is it?
36-inch. I mean, we get them so rarely in the hospital. It's just an outpatient admission gets.
Yeah.
They're just not used to it.
Yeah.
You just have to call the
Just
radiologist
call
yourself.
Oh, yeah, call X-ray.
Yeah, maybe we've done one in a year in the hospital.
Yeah. It was a couple Fridays ago. So juvenile idiopathic scoliosis represents 12 to 21% of the cases. And the transition from infantile to juvenile, so the 0 to 3 to 4 to 10, is associated with pretty dramatic changes both in the sex ratio and the area of thoracic apex. So in infantile, it's really a 1-to-1 balance between male and female. When you hit juvenile, however, it goes up to 8-to-1 in females to males. And that change, we still don't exactly understand why that happens, and a lot of research has gone into whether it's a hormonal change or if it's something related to receptors, and really not much from a biochemical standpoint has come from it. Generally, juvenile idiopathic scoliosis, that 4 to 10 range, is much more aggressive than adolescent idiopathic scoliosis. So that really just hammers home the key point of screening and identification early is key. And the progression is directly associated with the growth spurt that happens during puberty. If there's anything that you take away, especially for the junior residents who are seeing patients over at Eggleston who may present with the scoliosis, curves less than 25 degrees typically do okay, and you can get away with observation. Arranging for follow-up is important. Curves greater than 25 degrees, especially in the 4 to 10 age group, tend to progress, and most of those children are treated with bracing. So if you're not putting a brace on that child, don't just say, oh, well, routine follow-up, whatever. You're going to want to get them tied in with someone as soon as possible. So several case series have looked at curve progression and the need for surgical treatment in juvenile idiopathic scoliosis. Charles et al. Imagined 205 children, and this study, 15% of the curves that were less than 20 degrees progressed and required surgery. 75% of the curves between 20 and 30 degrees progressed and required surgery. 100% of the curves greater than 31 degrees required surgery. And the overall surgical rate in the case series was 50%. So out of 205 children with scoliosis between ages 4 and 10, 50% of them had surgery. School screening programs have showed the prevalence of adolescent idiopathic scoliosis to be about 1 to 15%. However, if you break that down further and look at curves of just 10 degrees or more, the prevalence was actually much lower, 1.5 to 3%. So what are the options for in adolescent scoliosis? Well, there's observation, bracing, and surgery. So we'll just go down the line. What are the long-term outcomes of observation? So there are some key landmark natural history studies, but the takeaway is that the long-term outcomes of observation are really poor at best. Without intervention, especially for larger degree curves, there's significant back pain, significant disability, and really the most surprising to me, and I guess it's interesting since we're neurosurgeons and spine surgeons are more like orthopedists, so we don't think about the heart and lungs, but cardiopulmonary compromise is actually the key biggest reasons for disability in this patient population. So the first landmark study was in 1968 by Nilsson and Lundgren. They had 50-year follow-up for adolescent idiopathic scoliosis, which is unheard of. They only had 10% loss to follow-up, which would be a record in a study like this. 45% of the patients died who started out with adolescent idiopathic scoliosis, which was twice the death rate of the general population. The highest rate of death occurred after the age of 45. 60% were due to cardiopulmonary disease. Of those that survived, 90% had back pain, 30% were on disability, and I guess in 1968 this was a key consideration, especially since the majority of this population were female. 76% never married, and thus were societally incompetent or something like that. So key limitations of the study, they had no reported radiographic measurements, so we don't know how big each of these curves were, if they progressed, and there was no correlation with etiology. So we don't know whether they had an undiagnosed congenital reason or if it was a true adolescent routine idiopathic scoliosis case. There was another study reported in 1968 by Nachemson, who had 38-year follow-up in 130 patients with untreated scoliosis. Similar to that first study, he showed a rate of twice the general population. If you subdivide it into thoracic-only scoliosis, the mortality rate was 4 times that of the general population, again, due to cardiopulmonary collapse. Parison et al. In 1992 actually went back and re-examined this cohort and found that if you subdivided it into infantile and juvenile scoliosis, That's actually the group that contributed to the higher mortality rate. It was not adolescent idiopathic scoliosis. And so this was a key first change about how do we consider those patients for observation and those that are going to need to be operated on pretty urgently. So 3 important questions. What percentage of cases will progress? Is it possible to predict which curves will progress, and what are the effects of untreated scoliosis? And so when we're looking at adolescent idiopathic scoliosis, you want to divide it into 2 further groups. Pre-skeletal maturity, where all the studies focus on risk factors for progression of the curve, and post-skeletal maturity, which focus on the radiographic and clinical outcomes.
Has anybody figured out why? Is that like something that with the thoracic, I'm assuming increased thoracic kyphosis, it decreases their lung volume or something?
Yeah, reduced vital capacities and reduced cardiac output. So risk factors for curve progression. Age, the younger you are, the higher risk you have. That sort of makes sense, right? You have more years for your curve to progress than someone who's older. Females are at higher risk for a curve progression. Those females who are pre-menarche have a higher risk. If you have a present Risser sign, which again essentially just correlates to skeletal maturity, you have a higher risk. A curve pattern, double curves have a higher risk than a single curve. And the larger the curve, the higher risk for progression. And since that time, we've had several of the longitudinal cohort studies from 1968 to 1981, which was then re-examined in 2003, 86, and 88. And the major takeaways from the cohort studies are that curves less than 30 degrees rarely progress. So this is adolescent idiopathic scoliosis, greater than age 10. Curves that are bigger than 50 degrees per year progress at about 1 degree per year. And the mortality rate, the prevalence of back pain, and the prevalence of depression are no different than those of the general population in adolescent idiopathic scoliosis. So that's the key differentiation between juvenile and adolescent. Thoracic Cobb angles greater than 50 degrees were associated with decreased vital capacity and frequent shortness of breath. And interestingly enough, the other major takeaway was that cosmetic deformity was actually a very major consideration in this patient population, which has led to one of the key subcomponents of the Scoliosis Research Society validated survey instrument that's used now. But the lower body satisfaction scores were lower, and 32% of those in these cohort studies indicated limited quality of life due to their deformity. Whether they felt like they were hunchback or something like that, they had significant cosmetic concerns. So the natural history varies by etiology. We discussed the treatment options, observation. Didn't really go much into bracing or actual surgical technique, but we'll review some of those in the adult portion of the talk. Pre-skeletal scoliosis is directly related to the growth potential of the child. The more years that you have to grow, the higher chance you have of your curve to progress. And post-skeletal scoliosis, the size of the curve really is the major consideration for whether you need to have treatment or not. So kids are great, but what about adult spinal deformity? That's really the thing that we're going to see more of. Corey?
Those kids that don't progress, do any of those ever normalize?
Typically not, no. Once you have a scoliosis, it doesn't go back or doesn't change. One of the first and major causes of adult spinal deformity would be a juvenile or adolescent spinal deformity that is either untreated or undertreated. Degenerative causes, which we see quite commonly, especially over at Midtown, and iatrogenic, which I think is probably a much bigger problem than anybody's aware of, and it happens pretty frequently. In fact, Dr. Gary showed some interesting films of a patient who just came in who started out with a single-level laminectomy and now has a 90-degree lumbar curve. So it can change pretty dramatically. In adult spinal deformity, the presenting symptoms and complaints are quite different than adolescents. Some may come in complaining of cosmetic issues, although that's generally not the biggest issue. Some come in with radiculopathy, but the 3 most common complaints are pain, pain, and pain, specifically back pain. the natural history of adult spinal deformity is less similar to scoliosis and really much more similar to degenerative spinal disorders, which I think has been part of the difficulty in kind of encapsulating and classifying the correct treatment for early adult spinal deformity. Key considerations are age of the patient. You're never as young as you are today. All the medical comorbidities, bone health and quality, especially in the osteopenic and osteoporotic patient who has not been treated or not been diagnosed. Considerations of quality of life. So what is the point of putting someone through a huge major operation if their quality of life is pretty poor at this point, as well as life expectancy. So what are the techniques that are best for treatment? First, just a quick review again of the coronal curve and sagittal modifiers, looking at the SVA, pelvic tilt, the spinopelvic parameters. The big difference in surgical treatment of spinal deformities is that adult deformities are generally fixed. And so the techniques that we would use in adolescent or juvenile deformity, things like derotation maneuvers and compression distraction techniques, are really not available in the adult because of these fixed deformities. There are definitely different flavors of adult deformity based on both the radiographic and spinopelvic parameters. And all the decision-making is going to be based not only on what all your measurements are, but also on the patient presentation, what their symptoms are. The one important takeaway, again, so if we had the one takeaway about adolescent and juvenile scoliosis, the important takeaway for the junior residents for adult deformity is that sagittal balance is the most important factor for quality of life. It has been directly shown to be correlated to the health-related quality of life outcome scores. So typically in juvenile and adolescent scoliosis, the main consideration is the coronal curve. That's really the driver of treatment. In adult deformity, really the sagittal balance and sagittal alignment is the most important thing. There was a paper in Neurosurgical Focus that came out and showed different types of deformities. So this is a patient who has an SVA of less than 6 centimeters. Their lumbar lordosis pelvic incidence mismatch is about 7 degrees. They've got a slight lumbar curve. So is this deformity? I don't know. Probably not. I think if any of us saw this in the office, you probably would say not a spinal deformity. So what about this? Now you've got a patient who's got a sagittal vertebral alignment angle, measurement of greater than 6 centimeters. Your lumbar lordosis pelvic incidence mismatch is now over that 10 value, but still looks pretty good. Slight, looks like degenerative curve in the lumbar spine, but too bad. What about this? So now you've got a mismatch of 25 degrees. Pelvic tilt is 25 degrees, so you actually have someone who's really trying to retroflex their pelvis to keep their head over their pelvis, but is not doing such a great job. And the main takeaway from this paper was, well, how do we decide which treatments are available for which patients? And I sort of used this paper as a segue into what I view as really the key techniques for adult deformity correction. But this was from a proposed framework for decision-making in minimally invasive adult deformity surgery. And the argument was that both of these cases are adult deformities and can be treated with minimally invasive surgery, but that this patient is still an adult deformity but probably doesn't qualify for minimally invasive surgery. I would probably go as far to argue that Class 1 and Class 2 are probably not adult deformities, just based on their measurements alone. And this Class 3 category, where they advocate for open surgery with osteotomies and extension of fusion in the thoracic spine, that's probably an adult deformity. If you're having to do that, that's an adult deformity patient.
Griffin, I agree with you. The Class 1 and Class 2 that people talk about, it's like part of the, deformity mafia. That everything is a deformity. You have to just look at it more carefully, right?
Yeah.
But that's not really, especially if you go back to the previous X-rays, just for residents. If you look at the top of the L1 and which way L1 pointed, the L1 is pointing back overall. In general, that in general will not be a deformity. In general, it could be, but for most cases of adult degenerative scoliosis or deformity, just look at that and usually you'll be all right. You're not, you can get away without doing a major like a scoliosis correction. You know, you're in class 1, class 2, like the little, what they call Hollywood curves, a little bit here and there, the deformity that you fix at MIS.
Yeah. So what are the techniques are bread and butter skills for adult deformity correction? Pedicle screw fixation, inserted posteriorly, as you guys know, and for the junior residents you'll get to see sometime. Interbody fusion, whether you insert the interbody posteriorly, posterolaterally, directly lateral, or anterolaterally, all are very powerful techniques for deformity correction. Osteotomies, which are going to be the bulk of what I'm going to talk about next, primarily because we don't see these often. And our understanding of what a true osteotomy is probably, and then our is the most important thing. All this work to try and decompress and realign the spine is nothing if you can't get it to heal. And that's going to be another important consideration. So Frank Schwab and some folks from the ISSG put together a comprehensive anatomical spinal osteotomy classification, which I like because it makes a lot of sense, and it also sort of avoids a lot of the eponyms, which over time have been kind of bastardized and become to represent things that they didn't actually initially represent. So a grade 1 osteotomy is a partial facet joint resection. That's it. So essentially all you're taking off is a partial facet. The power for this is relatively limited, and one of the key considerations for using a combination of grade 1 osteotomies to fix a deformity is that you have to have anterior column mobility, because if you take away a small amount of bone posteriorly, you've got to be able to then close it down. And so the concomitant closing posteriorly has to be matched with a slight opening anteriorly. And the lack of anterior column mobility can lead to complications, specifically seen in the natural history of like a Smith-Peterson osteotomy, which Smith-Peterson osteotomies were initially done for ankylosing spondylitis. And those osteotomies require significant force exerted where you actually fractured the anterior fusion mass. And in many of these original studies looking at Smith-Peterson osteotomies, there was a not insignificant rate of aortic transection from those bone fragments that were then exposed in fish mouth anteriorly. You can expect about a 5-degree to 10-degree correction per level. It's probably going to be closer to that 5-degree number. And like I said, previously referred to as a Smith-Peterson, chevron, or an extension osteotomy. A grade 2 osteotomy is essentially now a complete facet joint resection, taking the complete inferior articulating process as well as the superior articulating process. You can also resect the ligamentum flavum as well as part of the lamina or spinous process if needed. Again, requires pre-existing anterior column mobility. And any osteotomies that remove bone from the vertebral body are excluded from this grade. So that's a very important consideration, because the difference between grade 1 and grade 2 osteotomies and then moving up into grade 3 is really, that's the big decision point. Again, you can expect about 10 to 15 degrees of correction per level, probably closer to that 10-degree level. And this has been previously referred to as a Ponte osteotomy or a Briggs osteotomy. The grade 3 osteotomy is really going to be your primary workhorse in adult spinal deformity. And this has previously and more commonly is referred to as a pedicle subtraction osteotomy. So this involves a partial wedge resection of the posterior body, posterior elements, as well as the pedicles. But the key differentiator is that the disc above and below have to remain intact for it to be a grade 3 osteotomy. It's interesting, I was talking to someone who said that they had someone come into clinic who had a reported pedicle subtraction osteotomy, who had pedicle screws in the pedicles at the level where they did the PSO. That is probably not a PSO. So it's important to know that you are taking down the pedicles and going into the vertebral body. You can expect, again, 25 to 35 degrees of correction per level, previously referred to as a pedicle subtraction osteotomy, closing wedge, or a transpedicular wedge resection. Really the key technique here is to ensure that there is not too much bone that is resected anteriorly. It really has to be a wedge, because if you just take a big square out of the bone, you don't get any correction. In fact, you can actually worsen the deformity, because then all you're doing is just plopping one piece of the bone down on the other. You're doing a partial corpectomy. A grade 4 osteotomy is an extended PSO. So this involves a wider wedge resection through the vertebral body. It can include the end plate and a portion of at least one of the adjacent discs. If you're doing this in the thoracic region, it may require rib resection, because those ribs will actually hit and prevent you from fully closing the osteotomy. And this can give you a few more degrees than the PSO, 30 to 40 degrees, and previously referred to as a modified Smith-Peterson or a PSO plus a disc resection. The grade 5 osteotomy is your vertebral column resection, and this is a complete removal of a vertebral level in both adjacent discs. This has been known as a VCR. The key difference, and a lot of people ask the question, is what's the difference between a VCR and a corpectomy? A VCR is where you're removing all of the discs and all of the bone, and then you may not put a full-size spacer, but you're putting something in anteriorly that then you're closing and compressing the spine on. So a corpectomy is you're removing bone and you're putting something back and restoring that height that was there before you started. A VCR is you're actually shortening the posterior column. So that's the key difference between a corpectomy and a VCR. So we'll sort of start concluding here, but why do these operations from the back, especially with the power of these direct lateral and anterior lateral operations? Well, really, oftentimes in the adult spinal deformity population, there's lumbar stenosis, and you're going to need to do a decompression. And so you can only do that from the back. Also, your ability for correction, you have all of the techniques at your disposal. And the risk-reward is really the consideration for doing combined anterior and lateral approaches. There's definitely a role for it, but I think probably there's a lot of people who are losing some of the bread and butter operative skills in favor of doing direct lateral and anterior lateral approaches. And really, as the adult population starts to age, they live longer, their quality of life is better, their expectations for what they're going to do in their 70s and 80s are going to be greater and greater. And so for patients who've had previous back surgeries or just develop degenerative scoliosis, we're really going to have to continue to have these skills in our armamentarium to be able to treat this population. The other big differentiator between the lateral and posterior techniques is that there's really kind of a lack of long-term follow-up on the lateral and anterolateral approaches, and so certainly there's very pretty x-rays that come out of it, but we need to demonstrate durability over 5-10-year follow-up. So just within the deformity world, I mean, there are so many different topics that we could talk about. The different classification systems, the actual operative techniques and treatments for adolescent idiopathic scoliosis, surgical techniques, including revision deformity surgery, neuromonitoring, intraoperative navigation and robotics, arthrodesis techniques, as well as bone metabolism. I have got a couple talks already on post-correction concerns, biomechanics, PJK, instrument failure. We could also talk about the non-spine impact of spinal deformities, especially some of these imaging and clinical evaluation tools like EOS and SurgiMap, which are fantastic. So really, if you guys have any thoughts about spine-related topics, I would love the opportunity to put them together and be happy to take any questions. But that's a 50,000-foot overview of spinal deformity.
Griffin, can you hear me?
Yes.
Can you just make a few comments about bone density and some of the requirements when you're operating on the elderly or older patient with scoliosis?
Yeah, sure. So like we were talking about, the key operative techniques are obviously instrumentation, osteotomies, and then arthrodesis. And so, number one, if your instrumentation is going to hold, if you're going to have any chance of holding this, the patient's spine together, you've got to have a bone density that's strong enough to hold screws or hooks or whatever your technique may be. And so, virtually the preoperative workup for all these patients includes a DEXA scan. And if they have any osteopenia or osteoporosis, really they need to see either an endocrinologist or rheumatologist or whoever is managing their bone density. One of the newer medications that's on the market that has become very popular in the deformity world is teriparatide, which is Forteo, which is recombinant human parathyroid hormone, and has been shown to really activate osteoblasts and has a significant impact on arthrodesis rates as well as preventing proximal junctional kyphosis in a lot of these patients. Unfortunately, it's very expensive and is very difficult to get approved. You know, the bisphosphonates are some of the older types of medications. I would say those are probably not as popular, specifically because they do show some impact on fusion rates, and so really, you know, a pseudarthrosis or an instrumentation failure in one of these adult deformity patients can be a pretty catastrophic event.
What's the turnaround time? Let's say you get a patient in to see an endocrinologist, get a DEXA scan, oh, they're osteopenic, we're going to give them Forteo, everything is paid for. Is it like a year before you redo the DEXA scan and they improve? What's kind of the general gestalt of how
I think the first follow-up is generally about 3 to 6 months to try and see if there's been an improvement. But yeah, it's you know, adult deformities are typically not viewed as emergencies. You want to make sure that you have all of your workup completed and all your ducks in a row because you want to do the right operation the first time when it becomes this complex. All right. Yeah, thanks.
Nice job.